Good afternoon. My name is Allison Drew. I am the program coordinator for the Iowa Regional Autism Assistance Program. Welcome to the Autism Basics Webinar Series featuring Dr. Jillian Reiher. This session is on therapy options. Now, I would like to give a friendly reminder that certificates of attendance and foster parent training credit are available for the live sessions only. And now I'm happy to introduce Dr. Reiher. Jillian Reiher fell in love with working with children with disabilities, both on the ice teaching ice skating and providing in-home behavior support after college. She earned her PhD in school psychology from Illinois State University and completed her pre-doctoral internship and postdoctoral fellowship at the Monroe Meyer Institute in Nebraska. During her postdoctoral fellowship, Jillian participated in the LEND training program. She's been a staff psychologist at the Center for Disabilities and Development since July of 2020, and in that role, Jillian sees children for evaluations and therapy. She is on two of the Center for Disabilities and Development's autism diagnostic teams and has been trained in Project Impact. Jillian also spends a day per week in the Biobehavior Services Day Treatment Program. Dr. Reiher also serves as the psychology technical consultant for Iowa's Regional Autism Assistance Program, and outside of work, Jillian is the proud owner of an adorable and sassy bunny. As we go through the session, questions can be typed in the Q&A box below, and Dr. Reiher will respond to them at the end of the session as time allows. And now I will turn it over to Dr. Reiher.
Thanks, Allison, and thank you all for being here today to talk about therapy options. We're going to start with just some general thoughts on interventions and then talk about the evidence-based for some of the many interventions that are said to be for autism, and then talk about some of the therapies that are most commonly used. So just as a to put it all out there, my bias is I come from a scientist practitioner model of training where both um, understanding the evidence base behind things and putting those things into practice is considered important. I also wanted to note that most research on evidence-based therapies for autistic individuals was completed were with children and adolescents. So there is some more research now being done with autistic adults, but much of what we'll talk about today has been research with children and adolescents. As some general thoughts, intervention should always be done with specific goals in mind. Autism, as we talked about last week, is a very broad spectrum disorder, and so it's really hard to say this intervention is good for autism, as much as it is to say this intervention is good for increasing social communication or flexibility or play skills. Um, those interventions should be individualized. They can also be used to improve daily living skills, academic performance, decrease challenging behaviors, or address co-occurring medical or psychiatric conditions. They should be written collaboratively, certainly with family members in the case of children and adolescents, and then in older children and adolescents with um, the autistic child or adolescent themselves. And the progress should be assessed and shared routinely. So, um, at any given point in an intervention, you should be able to ask the therapist, where are we at? How are we doing toward those goals that we talked about at the beginning? We'll always want short-term treatment goals to provide scaffolding for long-term outcomes. So a lot of times people will come in and say, my biggest goal is that I want my child to talk. And that's a great goal. And it's one that I always say is kind of never off the table, but it's often not where we start. So if the child is pre-verbal and not making a ton of sounds yet, we might start with things like, um, attending to what other people are attending to or imitating others with the goal of eventually increasing vocal speech. There is some research starting, as I said, to look at adult goals areas. And some of those might be understanding and responding to social cues. It's really hard to be safe in the world if you don't understand the social information that other people are providing. Living independently or with as minimal supports as possible, developing close friendships or romantic relationships, accessing meaningful daytime activities. So that could be employment, volunteering, whatever makes sense for that person. Managing day-to-day stressors and then managing co-occurring psychiatric symptomology like anxiety or depression. So why focus on evidence-based? There are so many interventions that are reported to be for autism, hundreds. And some therapies have little to no research showing that they are effective. Um, Time and money are limited resources, and honestly, so is hope and energy. So I hate to send families to therapies that are less likely to work for those reasons. When I'm talking to families about the therapies that I think would be best for their children, I recommend, and then, or if I'm the one providing that therapy, I choose therapies that I think are most likely match the patient or family's goals and desired outcomes. If you come to me and say, I really want to work on toilet training, then we are going to go with um, probably some structured behavior intervention as well as possibly occupational therapy or something like that to ensure that the child can sense their bodily needs appropriately. We're also looking for interventions that are available. There are a lot of areas where there just are not that many therapy options and that are a good fit for the family. ABA is one that we'll talk about more today. I talk about it a lot, but a lot of ABA therapy tends to be fairly time intensive. And for some families, that just doesn't work. And I never want people to sacrifice their family life for a therapy. There are some good sources that help us get some information about which treatments or interventions are most helpful for autistic children. The American Academy of Pediatrics has some good stuff. The National Autism Center, National Standards Project is good, although at this point it is a bit outdated. Um, National Clearinghouse on Autism Evidence and Practice is fairly recent, more in 2020, but honestly, where I go most of the time is the Association for Science and Autism Treatment. It's a website that is updated as they get new information. And you can type in, like, hey, I heard about this supplement on there, and it'll pull up any available research. Oops. So I want to talk about a few different categories of therapies. The first is those that are supported by scientific evidence at this time. So this means that there have been some, in many cases, many well done studies indicating that they address the behaviors that they said they were going to. So, applied behavior analysis, or ABA, which includes things like functional communication training, and we'll talk much more about that next week. It also includes direct instruction, so having a very specific skill, teaching it in a structured manner, peer modeling, early intensive behavior intervention or treatment, picture exchange communication system, or PECS, self-management, teaching children to recognize their own behaviors and monitor them on their own. Um, Sibling training, so helping siblings understand how to implement some of the interventions that will help autistic children. Video modeling can be incredibly helpful for teaching many new skills. Visual activity schedules is one that I recommend almost all the time. speech therapy, some medications, and we'll talk a little bit more about that later. And then for older children and adolescents and adults, and those who are more verbal cognitive behavior therapy. There are some therapies that are currently in the needing more research category. And one of them, and some of them are fairly commonly used, and ones that I would recommend or recommend that people look into themselves. Um, so there's one highly structured program that we'll get some more information on later. The Teach program, elements of that are used a lot in school. Um, Also, technology-based treatments using computers or other electronic devices that includes things like augmentative and alternative communication, so using speech generating devices. Music therapy, again, has some support, but is not considered fully supported at this time. Social skills groups, social stories, so having um, writing out or having in pictures the expectations or what is going to happen in a certain situation, or relationship development interventions that are generally for young children and focus on building the relationship between the parent and young child. Then there are therapies that don't work or are untested, and these vary, I'd say, pretty widely between like animal therapy depends on the type of animal, how much testing has gone into that at this point, to ones like facilitated communication, where there's been a lot of assessment to show that it is not effective. So sometimes families ask me if something like horseback riding therapy would be helpful for their child. And my answer is usually maybe. It depends. Does your child like animals? Do they feel comfortable around them? If so, I think it's as good a way as any to work on things like following directions, respecting somebody else's boundaries, communicating for what you want and need. I think that's great. Um, but then, as I said, there are other therapies that like facilitated communication that have been pretty thoroughly shown to be ineffective, and others like certain high doses of vitamin or chelation that can actually be dangerous to the child if they are not necessary for a medical purpose. There are, as I said, some medications that treat specific symptoms of autism. So there is no medication for autism per se. Um, But there is some evidence for, or good evidence of effectiveness for risperidone for severe disruptive behavior. So that would be severe aggression or self-injury, and methylphenidate for ADHD symptoms. This is not meant to be taken as medical advice. I'm a psychologist, so always work with your medical provider to determine the best course for your specific child. But these are just some general research findings. Also, individuals with autism have been found to be more sensitive to psychoactive medications and have more side effects, which is important to consider when you are thinking about whether medication will be a good fit for your child. With autism, we can have many co-occurring conditions such as seizures, GI problems, dietary imbalances caused by food selectivity, disrupted sleep patterns. And so we really want to make sure that we have a medical home or some single provider or group of providers who are looking through all of those things and viewing the child through that whole picture. And the child might also benefit from medical care to manage some of those problems. So if there's GI disturbances like constipation, they might prescribe a laxative or something like that. So I want to talk a little bit about two of the more common approaches to behavioral interventions for children. Teach is a structured teaching method you'll see in the video. It is very, very regimented, and not necessarily in a bad way, but just in a way of making it incredibly clear to the child what is going to happen. And then pivotal response training is a natural developmental behavioral intervention, meaning that it focuses more on what is already happening in the natural environment and how do we, um, based on how the child is already responding to the environment, how do we set them up in new situations and teach them new skills in a more flexible way. So this first one is teach, and I apologize in advance if there's an ad. Nope.
My name is Alice, and I want to tell you about how I learn. I go to mainstream school. This is where I learn. It has structure with clear areas where my learning takes place.
Jillian, we all of a sudden can't hear the
I
video
share my
now.
learning
Oh,
space with lots
Now
of
we
other
can hear it.
children.
I can scoot that.
Different learning takes place. I also like to learn outdoors. I share my learning space with lots of other children. Sometimes it can get a bit much. My teachers help me when I feel like this. We worked out some ways together, which means I'm able to learn. First, they find a place for me to work, a workstation. My teachers show me my visual timetable. We work together so I can focus on what we're doing. And I can get my reward later. This helps me become independent so I can do my timetable on my own. If I get lost, my teacher uses a check your timetable card. When I know what my teachers want me to do, I go to my workstation, where I can work in my own structured way, with my tasks to do on the left, my workspace in the middle, and my finished work on the right. My teachers help me with my work schedule too. So I know what's going to happen now, next, and then. My teacher introduces the schedule, sometimes reminds me to use it to make sure the tasks are done. My teacher has to remind me less and less. I like it when the tasks are laid left to right, and I know that there is a finish. I start with what my teacher calls a posting exercise. After this, we'll make it harder by doing a two-part posting exercise. We also work on matching activities, fine motor skills, and lots more. Once the work is finished, we put it in the finished box. I learnt the idea of finished by using my finished box. When I am done, I get my reward. Remember, structured environment, a visual timetable, schedule, and the idea of finished. When all this is done, I get my reward. And next time, I'll do my work to get my reward again. Bye. Thank you.
All right. So there are a lot of advantages to a structured approach like the teach method. Um, it's incredibly clear to the child what the expectations are. It's incredibly clear to the grown-ups involved what the expectations are. It provides a lot of that visual support, which, as we've talked about, can be helpful for so many children. Um, on the downside, it is a lot of work to get set up like that. Can imagine that was many, many hours of creating visuals. And then the other issue with it is sometimes the world is not cooperative enough with us to make it that easy to structure. So we might think that there's a certain plan for the day, but then there's a fire drill that we didn't know about, or a teacher has to go home sick, and so now there's a change in the child's instructional schedule. So it's a good system. It's still there are still things that are not always perfect about it, as is true with every intervention. This next video shows the more kind of naturalistic approach of kind of taking things that are already going on in the environment and teaching based on those activities.
Do
You need help, like you know.
need help?
You do? Yeah. We always knew Victoria was a special girl. She could count to 100, at age 2.
We were actually completely lost when Victoria was diagnosed with autism. So we found the Yale Medicine Child Study Center online. It seemed like that would be tough on Victoria, but potentially could get some results.
Parenting is hard, but parenting a child with a disability is astronomically harder. And providing parents with strategies that they can use is what empowers me every day. I'm Pam Ventola. I'm a clinical psychologist and an assistant professor at Yale Medicine Child Study Center. In autism, the primary areas of deficit are social interaction skills, language, and communication skills. That's your turn. Victoria is a patient that I've worked with for just over a year now. She's bright, capable little girl, but she wasn't motivated to engage with other people. Do just stickers or go fish? Let's play go fish. What we offer at Yale Medicine is individualized treatment. Pivotal response treatment is abbreviated PRT. It's a behavioral treatment to support language development and social interaction. You want the rod? Yes, sure. For each child, we develop objectives, so very clearly defined behaviors that we want to improve. I got another clean one.
I'll dump the rest.
Victoria's goals when we first started working with her included making eye contact with the person she was speaking to, and also using her language to help her begin to engage in conversations.
What did you get?
I got the bird. A lot of the kids that we work with, Victoria included, love bubbles. And we can use these bubbles to motivate the children to communicate with us. So the child would need to use their words, a lot of bubbles or just one bubble.
A lot.
And then I'd reinforce it by blowing the bubbles.
When Dr. Ventola and Victoria were working together, you could kind of see on Victoria's face, this is what I can do. This is something that I can say to get what I want and be motivated.
Did you get a son? No, but I've got something else that I think you really like. Blue? Your favorite. This is great. I like how you're prompting her.
For all of our sessions, Victoria's parents observed or were interacting with Victoria with us.
Wait a second. No, your face is better. Ready? All right, close your eyes.
I definitely felt hopeful. I watched this and I thought, my kid really isn't that different than any other kid. She just needed different tools.
Yeah, close your eyes, Mom.
It required a great deal of commitment from us to take home the things that Dr. Ventola was teaching us in that setting.
31.
What pieces
Out of
Victoria? The reaction was an amazing transition from where she was to where she is today. We were nervous going into this kindergarten year. Where would she be in relation to her peers?
Tori and Sammy, can you put that away? We're gonna get.
As soon as we got her on school grounds and we saw her engaging with the children at the school, we knew that she had that confidence and she had the ability to communicate and do what she needed to do to excel at school. She now has skills that we never thought would be possible. So it was a big change for us and for her.
When you are going through this process, you wonder if, is there something I'm doing wrong as a parent? Do I not know how to help my kid? And I think we just learned how to be confident. It teaches you how to believe in yourself as a parent with a kid with special needs.
So before we talk more about that one, the one disclaimer I always give on this video is that we have pretty decent evidence at this point that eye contact is not a great goal to have for children with autism. For some of them, it might be distressing. For a lot of them, it just isn't necessary and might actually pull some of their focus away from what we actually want them to be engaging in. So depending on the intervention I'm doing and how much we're working on social interaction stuff, I might see eye contact increase kind of as a byproduct, but it's not ever anything that I'm directly pulling for anymore. However, the increasing language is a great goal, and especially that increasing social language. So you can see in the video how the therapist and her parents used kind of natural prompts like, oh, look at this cool thing that I have, or it's something you really like, or gave her options and modeled language on how to say things. Do you want a little bubbles or do you want a lot of bubbles? It isn't as structured. Um, and so it can be nice for kids who either aren't ready for or don't enjoy that level of structure, or it is a nice one for families to implement at home because most of us do not have our home set up like a teach program. And like I said, it's a lot of work, and life isn't always kind enough to let us have an easy schedule made. But the pivotal response training and the more naturalistic developmental behavioral interventions are usually more implementable at home. If you go on the Interacting with Autism YouTube channel, you can find some additional examples of supported and promising interventions for autistic children. The Autism Internet Modules is also a great resource. It requires a username and password, but it's free. And they've got stuff from little ones all the way up through transitioning to adulthood, supportive employment. They add more every time I look. I think they're at like 50 different topics right now. So given that there are so many therapies, how do you choose? Well, the first one tends to be, is it available? Telehealth has made more therapies more accessible than they were before. I'm not going to say that everything is at the level that we wish it were, because that's certainly not true, but there are at least some more options. We also want to look at the therapy's effectiveness, its research support. You also then want to look at, do the therapist goals match your goals? If the therapist is saying, well, I want to work on sitting at a desk, and you're like, yeah, I don't care about that, but I want them to be able to play in a certain area independently for a period of time. It may not be the right fit. Although, like I mentioned earlier, we do often have times where we have short-term goals that are leading to those long-term goals. So, like I said, if you're saying, I want my child to engage in back and forth play, and your child isn't quite yet imitating others, that might be an area where they start. And so that's always a good conversation to have with the therapist is, are our long-term goals matching, and does it make sense the way that they're trying to get to those long-term goals? Definitely want the therapist to have a good relationship with your child and or your family. You and your child are probably going to be spending a lot of time with them and teaching your child some important things. So you definitely want to make sure your child feels comfortable and that you feel comfortable. You want the therapist to work with your family. So a lot of times we think of therapies as things that we just drop a kid off and they do like we might do as adults. But for children, that doesn't tend to be the most effective way to intervene. Usually, we need to support them within the systems they're in, so their families and their schools. And then also looking at, does the therapy work for your child, regardless of what the research said? So, like I said, there's a lot of great high quality research on early intensive behavioral intervention. But if your child is very little and they still have a nap and that just isn't jiving with the schedule for therapy, that's okay. You'll also want to know if an intervention is working, especially if it's taking up a lot of your time or your money. So try, if at all possible, to start new interventions at different times. So a lot of times when kids are first diagnosed or when you first have concerns that something might be going on, the the thought is like, let's get them into everything as soon as possible. Um, and I'm not going to tell you not to do that, but I am going to tell you to try to monitor what is starting when and what seems to be making the difference. Because if we start everything at the same time, if we change a medication and we start speech therapy and we start ABA and we start school, it's really hard to know what is actually making the difference, which is a problem if you ever want to pull back on those things. Because then I get families come in and say, we're burning out. What can we cut back on? It's nice if we know where we're seeing the most effectiveness. Definitely have a few key goal improvement areas in mind. So think about like, are you looking at your child's communication, their overall engagedness? Is it something more specific like toilet training or um, increasing um, their willingness to try new foods? Consider taking videos of your child doing those activities that you are wanting to improve across time to kind of compare their behaviors. I think this is a really nice tool that we have now that we did not have a couple decades ago. That it's fairly easy for most of us to take these little snapshots of their behavior because a lot of times our memory is not that great. So, you might say like, oh, my kid is really not making progress at all. And then because, they're not talking yet. But then you go back and you look at videos and you're like, oh, actually 6 months ago, they weren't even orienting toward us, looking toward us, engaging with us at all. And now they're doing those things. Now they're playing peekaboo with us or patty cake or some of those more back and forth games. And, they're starting to vocalize more. Yeah, they are improving. Um, and it can be something as concrete as putting on a shirt or something less concrete like joint attention or that attending to what other people are attending to, or like I said, staying engaged in an activity with another person. And watch your child's mood. Every child is autistic or not, is going to have times where they feel mad or sad or upset, especially when we have changes in routine, especially when we're starting new therapies. But overall, there should be either no changes or positive changes. So one of my favorite parts of, I used to do some um, ABA programming for preschoolers with autism. And one of my favorite things is that we would eventually see decreased distress and more smiles when a kid was better able to communicate, when they understood what was going to happen and what things that they did were or were not going to get them the things they wanted. There are also complementary and alternative medicine treatments. That refers to anything developed outside of mainstream Western medicine and is often used again alongside conventional medicine. So a lot of times people aren't choosing either or. Commonly used categories include natural products, mind and body therapies, and other biomedical treatments. These treatments are often selected to promote wellness, treat specific symptoms, avoid side effects of more conventional treatments, or attempt to resolve core symptoms of autism. Measurements of complementary and alternative medicine treatment usage vary widely from about 30 to about 95%. And probably unsurprisingly, they are more likely to be used when there are co-occurring diagnoses and increased um, severity of autism-related behaviors, which makes sense. If things are tougher, you're probably trying everything you can to help your child. These strategies are used to treat general ASD symptoms as well as co-occurring symptoms or things that kind of co-occur like seizures, hyperactivity, sleep, GI problems. Most families who use some sort of complementary and alternative medicine use more than one treatment. And families rarely ask physicians about complementary alternative medicine treatments or report their usage. And this is where I would really encourage you to at least report the usage because there are some, particularly supplements and things that can combine poorly with more conventional medicine. And so it's good for your medical provider to know. At this time, there is very little high quality research on complementary health approaches for autism. Um, Several years ago, it was a pretty popular one, but there's a GI hormone called secretin. Um, Hyperbaric oxygen therapy, chelation, or antifungal agents, none of them have been shown to help with autism. And again, they can be dangerous for children. Chelation does have medical uses, but if it is used outside of those times, can be cause some pretty significant health effects. Melatonin might be helpful with sleep problems in autistic people, like it is in many people without autism. There have been studies on things like omega-3 fatty acids, acupuncture, mindfulness-based practices, massage therapy. Right now, the research is just not clear, and it is not recommended that they're used in place of more conventional treatments. Special diets is kind of the weird outlier one. So, for example, if a person has a seizure disorder, a ketogenic diet might be helpful, but that is definitely something that should be managed with consultation from their medical provider. Similarly, some children with autism benefit from a gluten-free, casein-free diet, but only if they had co-occurring um, GI issues related to gluten or casein. So there was a really well done study that was randomized and double blind, meaning that neither the families nor the clinicians providing the diets knew which child was getting which medicine. And they found that there were some changes in behavior and symptom reduction only for children who did have um, those previous gut issues. And so my recommendation when families ask about this is to, first of all, always talk to your medical provider, but also think about your child's willingness to eat a variety of foods, because my concern is always if there isn't a co-occurring GI issue that seems to be caused by the substances that we're eliminating, and then we eliminate many of the foods that the child feels safe eating, we can end up putting their nutrition in an even worse place. So again, definitely talk to your medical provider before starting dietary approaches. Also wanted to talk a little bit about what interventions are being used most frequently. As far as community-based services, as you can see in general, the therapies are more common for autistic children with co-occurring intellectual disability, with the exception of social skills training, which is at similar rates for both children with and without intellectual disability. Behavior modification, which again covers a wide range of interventions and therapies, sensory integration, cognitive behavior therapy, occupational therapy, speech. As far as school-based services for school-age children, so that would be ages 5 to about 18. Um, Again, much more common for autistic children who have an intellectual disability as compared to those who don't. But occupational therapy, physical therapy, social skills, speech and language therapy tend to be the most commonly used. And then as far as medication, um, in general, still higher rates of medication prescription for children with autism and intellectual disability, although stimulant use is higher for children without an intellectual disability. We also see things like antidepressants or anti-anxiety and mood stabilizers, antipsychotics, anti-seizure, which makes sense, especially given the co-occurrence of autism and seizure disorders at times, and for sleep. And then next week, we will be talking much more about treating dangerous behaviors such as aggression toward others, self-injury, and elopement. What questions do people have?
We do have a couple in the Q&A box. There's one that's just a comment saying that they had success with horse therapy.
Great. That's awesome.
How do you feel about service dogs to help kiddos keep calm and stay focused in school?
Yeah, I think what many families I've worked with have had the hardest time doing is finding a provider who can kind of give you the documentation you need for that. Because, like, I can't, I'm not trained in service dogs or anything like that. Um, I have my work with my family dog would tell you that I am not qualified to make decisions about what dog is or isn't good to be a therapy dog. I think they can be helpful for some kids. I think it does get complicated when you look at things like um, allergies in schools, but then also, um, you know, again, I go back to, is it helpful for your specific child? So in my hometown a few years ago, there was a whole thing about an autistic child in my parents' neighborhood getting letters written for therapy chickens, which sounded not real to me. But all of the neighbors were like, listen, the kid does much better when the chickens are around. Which I think to me speaks to how individualized autism interventions often need to be. And so I can't say definitively yes, a therapy dog would be calming for your child. But if it is and you have evidence of that and you can work with somebody who can get you the documentation you need, then I think it's worth a shot.
What about young adults with high functioning autism? This person did not have some of these therapies when they were younger,
Mhm.
and mostly has reading comprehension issues, some anxieties, what would be available for that person?
So probably depending on the setting or what is needed. So especially for the reading comprehension, I'm thinking potentially could get some accommodations through like a job or high school if they have documentation of those reading issues, um, or or college. For anxiety and those types of things, then I would probably go to that cognitive behavioral therapy.
What type of therapy would you recommend if anxiety is the key manifestation?
Yeah, I would, well, depends on the verbal abilities and on this I would include any sort of alternative communication. So if the person is capable of communicating in sentences in any form, and like converse, it can do the conversational, yeah, we'll say conversational speech, and I'm using speech really lightly to mean a speech generating device, sign language, anything like that. If they're at that conversational level, then the cognitive behavioral therapies are probably going to be the route to go. Um, if their language isn't quite there yet, we have fewer options, and it really is more the um, systematic desensitization and practicing things in small doses until they feel more comfortable with it and or medication management options.
We did also have some questions that were submitted ahead of the
Mhm.
webinar today. Is love and logic an effective parenting tool for families working with autism?
Yeah, so I could not find a bunch of or any research on it specifically related to autism and not much research on it in general, but I think it's one of those that falls into the evidence-based principles rather than evidence-based programming thing, by which I mean the things that they seem to be talking about as far as giving your child clear expectations and follow through, both providing less pleasant consequences like a timeout or grounding for when they do things that you don't want them to do, and providing more pleasant consequences like access to um, things that they like or praise or those sorts of things. Those are good behavior principles. So I would definitely throw that into the category of if it works for your child, go for it. Where I'd be careful with it is if your child is maybe not at the comprehension level yet where they can understand that reasoning. So um, verbal skills are not always the best understanding of a person's thinking skills, but it's kind of the best proxy we have sometimes. And so if they're not giving you good verbal reasoning yet, they may not be able to fully understand the verbal reasoning yet. Um, but yeah, if your child is conversational speech, again, in that any method of communication, I think it's probably a pretty good method.
What resources are there for teaching or learning things like daily tasks, tying shoes, riding a bicycle, and personal hygiene?
Mhm. So usually what I do is I will look to see, I will literally just Google and see if anybody has come up with a task analysis, so a breakdown of the steps needed to teach those skills, um, and pull that from them. A lot of times they already have visuals created. If they don't, then oh gosh, and I haven't done this in a couple of years, so I don't even know if this website is still active, but eHow, or I think there's WikiHow, they will break down skills that I never would have even thought, like putting on a shirt or vacuuming. And from there, you can kind of adjust and take your own and say, like, oh, I know my kid can do this step, or, ooh, they have this as one step, but I think I'm going to have to break this down and teach it as two, and create your own visual supports for that too. So there are some websites, and again, I usually just Google, that will let you do some free online creating visuals, but truthfully, most of the time I just pop things into a Word document and pull pictures from Google Images.
Any advice to help with refusal or tantrums to participate in speech appointments along with transition into ABA?
Mhm. So I think, and we'll talk about this more next week, but I think the figuring out the what about the transition or about the participating in the appointment is problematic for your child. Is it separating from you? Um, is it that they have to give up something that they were playing with their favorite toy in the car and now they can't? Is it that they're going to have to do work in those places? Is it a fun combination of all of those things? Um, so one thing that can help with the transition is to have some sort of fun transition activity. So have a visual that says, okay, first we're going to walk into ABA, and then you're going to do whatever their favorite activity is there. And with if I were the therapist in either of these cases, I would probably, and if we're seeing like big blow-ups or meltdowns over just the coming into therapy, I'd probably back off and continue try to build some rapport and really get that child comfortable before we go into more of the structured learning activities. But like I said, also looking at what are the factors that might be upsetting them can be helpful too. So is it like the parent needs to separation from the parent? Okay, do we need to practice that a little bit more? Is it transitioning away from a toy? Well, do we have to transition away from that toy at that time, or could we do it later once we've already started something more fun in the therapy? Those would be kind of my thoughts on that.
Does dyslexia happen as a manifestation of ASD or is this separate?
I have not seen any research on it being a manifestation of ASD, but it certainly can co-occur.
Have you looked at the work from Jim Adams from Arizona State on, I apologize if I say this incorrectly, but microbiota transplant therapy, MTT, and the gut microbiome?
Yeah, I hadn't, so I did last night. And this person was kind enough to submit this question in advance so I could do some more looking into it. I started where I told you guys I start with the autism or the Association for Science and Autism Treatments, and did some typed it into there, and their findings were that there is no real research to support it at this point. And so I went to the website that was linked, and one thing I liked on the website was that it did say, although we're looking at medical interventions, you absolutely should still be using high quality educational and behavioral interventions in in conjunction with what we're doing. The only article that I could find linked there was from, I believe, 2017. So they did report some improvements, but a couple things stood out to me about the study. It was a fairly small sample size. It was, I think, 16 to 18 children. Um, it also was not randomized or blinded, meaning that um, children were not placed in a condition based on, or they were not randomly placed in a condition, and the parents, potentially even the children, knew that what what treatment they were receiving. And that's important because the placebo effect that you might hear about sometimes is real, and that's the idea that if you think that you have a medication or you're taking something, that you see effects from it, even if it's a sugar pill, even if it's nothing. I did it to myself with decaf tea one time. I was like, oh, this tea is really giving me the energy I need. And then I looked and there was no caffeine in there. So it is a real thing that happens, and it is certainly something that I'd worry about in a study like that one, where it's primarily self-report data from the families. Also, those children all had moderate to severe GI issues. And another thing that I thought was interesting is that, so they did compare autistic children to typically developing controls. And they found that the autistic children had significantly less fiber intake than their typically developing controls. And so I wonder, is that potentially an easier understanding of why some of those children might have GI issues. I don't know that. I'm not that kind of doctor, that kind of scientist. But those were some of my thoughts on it. If you have other more updated studies, I'd be happy to take a look at them too.
Um, Looking for some tips to respond for a child's meltdown and to extend his focus time to do an activity or play, and how to make him understand to not take his clothes off in public.
Mhm. So I'm going to break that apart, I think, into three different strategies, suggestion things. First of all, in an active meltdown, my priority is always keeping the child and then everyone around them safe. Probably you'll probably be doing more by doing less. And what I mean by that is a lot of times our gut is to try to say things to the child, to try to comfort them, to try to offer them things. And in that moment, they are potentially not even hearing you because they're so escalated and so upset. And so at that peak of a meltdown, um, what I tend to do is just kind of give the child space. Like I said, make sure that they're safe. You know, you can validate the feeling. I hear that you're frustrated. I see that you're, really upset. You can do that. But depending on your child, you may even keep the talking even more to the minimum because that might even be too much input for them. And then as they calm down, then you can start to ask, what do you need? Or show me what you want, or something like that, depending on your child's skills and abilities to communicate those things with you. Um, but at that absolute peak meltdown, that is how I respond, is we kind of keep that space for them, make sure that they're safe, and move forward. Um, the next part of that question was extending focus. So extending focus is a tricky one. I think finding things that your child likes is a helpful way, but also maybe understanding that focus for them might look different at this point, and it might be that instead of focusing on one specific activity, you have a set of activities that they can rotate through in that area. And it kind of depends if you're talking about extending focus for independent play, like, oh my gosh, I need to make dinner, I need them to do something. In that case, I'm going to say have some different activities set out that they can rotate through all of those. If it's extending work-based tasks, or like, okay, I need to teach them how to brush their teeth, then it's primarily going to be find a motivator, and set it up so that we're gradually increasing that time engaged in that task. And then can you remind me what the last part of that question was?
How to teach them that they need to leave their clothes on in public.
Yeah. Another tricky one. Again, depends kind of on your child's verbal and reasoning skills. If they're at a point where they can say things to you like, "Oh, I'm too hot," or "I don't want it," then you can kind of make more deals with them in terms of, if you leave your clothes on when you're out in public, then we'll do this fun thing when you get home, or something like that. If they are not, honestly, the best thing for it is probably frequent reminders, even when they are keeping their clothes on, blocking them when they go to take their clothes off. Um, Depending on your child, you may even do a reward or something intermittently as they are keeping their clothes on. So, hey, you're doing such a great job keeping your clothes on. High five, if that's something that's motivating for your child. Or here's a little bit of snack. Or um, you're keeping your clothes on so you can have access to the iPad right now, where you can play with this toy. It's tough though. That's a tricky one because they only need a second out of your reach
Mhm.
to, yeah.
My son used to struggle with that, and we started giving him the choice of what clothes he wanted to wear every morning, and we discovered he was often just choosing the same types of textures of clothes. So we figured it must have been something was bothering him sensory wise, and that seemed to help.
Yeah, that's a great point.
Well, thank you everyone for joining us today. And thank you, Dr. Reiher. I will send out the recording links and certificates of attendance later this afternoon. If for some reason you don't see it in your inbox, be sure to check your spam folder. Sometimes they like to hide there. But we will see you next week for the session on treating dangerous behaviors.